Welcome, listeners, to OstrowTalk. Today's episode is temporomandibular joint disorder, or otherwise known as TMD, and limited mouth opening. Hi, I'm Dr. Gannon Lee, practicing in Mission Viejo, California, and I'm finishing up my certificate in orophalangeal pain at the Herman Ostrow School of Dentistry. And in this episode, I am going to be talking about some temporomandibular joint issues that can come from your patients. I'll be talking about how to recognize some of these issues and what may be the cause so you can be more familiar and recognize them. Because heaven forbid, your last patient can't seem to open for the DO filling on number 18 right before you're taking a flight to Hawaii for your vacation. When a patient presents with a limited opening, one of the most important questions we need to ask and answer is why. A simple way to think about a limited opening is that either the muscles won't let the jaw open, the joint won't let the jaw open more, or something is physically blocking the jaw from opening. So in your patients, they may have a muscular issue called myalgia, which is muscle pain, or myofascial pain, which is pain with a referral pattern to a different location. So often both of them can create a feeling of tightness and soreness. TMJ disorders such as disc displacement without reduction, otherwise known as a closed or open lock. In your case, your patient may have a disc displacement without reduction where the disc is anteriorly positioned and stuck in front of the condyle. So your patient may have also a degenerative joint disease, in which case your patient is presenting with cracking noises and TMJ pain. They often involve locking episodes, stiffness, or even changes in jaw function. What you need to do is take a focus history and perform a brief examination so you can actually determine whether the problem is muscular, articular, or structural in nature. Remember, opening, which is limited, is not a diagnosis, it's actually a symptom. So your job is to identify the source and determine whether the patient can be managed conservatively or would they be benefited to a referral to a specialist. As a GP dentist, you should know what are the normal ranges of mouth opening and to actually diagnose limited opening. Normal opening ranges between 40 and 60 millimeters. If you don't have a ruler on hand, you probably have these things. Your fingers, if you have 3 fingers, if you put it in between the opening and you can stick 3 finger in, that's about 40 millimeters. A limited opening is any amount less than that. The patients will usually start complaining of that issue that they recently couldn't open fully. When a patient tells you that they can't open their mouth normally, one of the first questions you should ask is whether the problem started suddenly or gradually. A sudden onset often points us toward an intracapsular problem, particularly disc displacement without reduction. As I told you before, it's commonly known as a closed lock. These patients frequently tell you, my jaw has used to click, and then one day it just stopped clicking and I couldn't open. A gradual onset is more commonly associated with systemic disorders, degenerative joint disease, arthritis, or chronic pain conditions. Next, let's ask about a history of clicking and locking. So a history of long-standing clicking followed by a sudden reduction in opening is highly suggestive of the disc displacement without reduction. You may also want to understand the location and the severity of pain as well. Is the pain located in the muscles, such as the cheeks or temples, or is it located directly in front of the ear over the joint? So trauma history is also important. You might want to ask your patient if they've been in a recent fall or sports injury, motor vehicle accidents, or a previous jaw surgery even. Trauma can actually contribute to joint injury, fibrosis, ankylosis, and restricted opening. Once you've gathered a thorough history, move on to the clinical examination. We have to determine if it's a fibrous, a trismus, a contracture, or a disc displacement without reduction, so you need to check the range of motion. There are 3 types of openings we have to check for the patient. So the maximum pain-free opening, which is how much can your patient open without pain. If it's 40 millimeters or more, you're good. If it's less than that, you would need to check their maximum opening that they can do, even if there's some pain. So have them open, and if it's under that maximum, try to find out where the pain is. Have them point to that area with one finger. And also, lastly, we need to check for maximum opening, which is assisted. When we assist them, we would have them open, but we actually guide them. And using about 2 kilograms of pressure, we would push their teeth apart, seeing if we can get a soft end feel or if we get a hard end feel. A soft end feel is we can push just a little further with our assistance, whereas a hard end feel is we can't push any further, even with our assistance. It's pretty much stopped. So in trismus, the patient has pain and is guarding the opening because they're afraid that they're going to create the pain again, or maybe even pop their joint. So you usually will get a soft end feel in this case. You can push it open more, but the patient is concerned about the pain and they're guarding themselves. The mechanism is going to be muscle-based. In contracture, your patient has a firmer end feel because the muscle tightness has been more chronic. So the firm end feel may give slowly, but they have to do more of a sustained stretch. The mechanism is also going to be muscle-based. There are other conditions why patients can't open besides solely muscle, meaning the mechanism isn't always going to be myalgia or myofascial. So in fibrous or ankylosis, they will have a hard end feel, and usually the mobility and opening is the least. The mechanism is structural, like I said, and we would definitely recommend getting more imaging to verify this diagnosis. The other one would be the disc displacement without reduction. We also would get a hard end feel because the disc is stuck anteriorly and the mechanism is also structural. Also, MRI might be ordered by the dentist or orofacial pain specialist to verify the position of the disc. Lateral movements are also necessarily needed to verify other movements. So normal range laterally is about 9 to 12 millimeters. In trismus and contracture, you would usually see about these amount of movements normally. But in fibrous or disc displacement without reduction, these lateral movements are especially limited to the affected side. Certain patients may have more of a serious limited opening that you may have already been aware of if you review their health history, and it's going to be associated with these systemic conditions like autoimmune diseases. You may have patients that present with scleroderma, and in those cases, they are more of a chronic limited opening. Usually the onset has to be over three months or even years. Their muscles are already so tight that they can't and won't be able to stretch open. You may also be aware of conditions where they have fibrous tissue conditions such as from radiation, connective tissue diseases such as Perry-Romberg syndrome, which limits the amount of movement that they can do. That's why it's really important to know the patient's health history, even asking if they have pain in other joints. Being aware of the patient's osteoarthritis and rheumatoid arthritis conditions or status can be beneficial. That can affect the prognosis and help with right diagnosis. So to summarize, the clinical pearls that we have here are limited opening is not just a symptom, it's actually a diagnosis. A thorough health history often identifies the cause and the mechanisms. And then in terms of treatment, what are the options we have available? In the muscle-based issues such as trismus or contracture, we do recommend that patients do an untongue position. You put your tongue behind the front maxillary teeth, and while holding there, stretch open for 10 to 20 seconds like this. What we're trying to do is just stretch that muscle and create more perfusion in that area. Thermotherapy, meaning ice and heat, may be also used to assist in the stretching and comfort afterwards. And if your patient has more of a widespread pain, there may be a trigger point. So as an orofacial pain specialist, we would consider doing a trigger point injection to treat the trigger point and the site where there's an additional pain. For issues with pain in the jaw joint, which limits their opening, such as disc displacement without reduction, we would consider an intra-articular joint injection with a steroid. After injection, there are exercises we would recommend to the patient to perform and lubricate the joint so it becomes more flexible. So thank you, listeners. I hope you've learned a lot in this talk and can become more aware of the red flags that can appear in your office. If you have further questions, feel free to reach out to the Herman Ostro School of Dentistry, and especially the orofacial pain department, which is excellent. Or refer to an orofacial pain specialist if you run into a case that needs more assistance. Thank you, and fight on.